Okay, thank you, Dr. Ritchie. We'll be moving on as he and other authors have alluded to the discussion of not only a dual plate construct, but also a hybrid construct, including nail plate combination techniques, which we have been joined by Dr. Liporace and Dr. Yoon, who will be discussing their pre-recorded interview and then the question interview session.
Thank you for joining us, Dr. Liporace and Dr. Yoon, to talk about your technical trick manuscript nail plate combination technique for native and periprosthetic distal femur fractures. Can you start off by talking about what was going on at the time with distal femur fracture fixation that prompted this study and how this nail plate combination sort of evolved?
Sure. Probably about maybe 12 years ago or so, many of us were starting to notice that distal femur fractures, even when you try to follow all the principles correctly, they can result, especially in isolated plating, on having a later catastrophic failure. So patient may get a partial union, may start feeling pretty good, start ambulating, and then 6 months, 9 months down the road, you may have breakage, whether it be screws or the plate at the junction of the head and the shaft component of the plate, etc. And this is barring even maybe making technical errors like putting the lock screw just above metaphyseal comminution, trying to do appropriate transitional modulus and everything else. There was some deficiency there. So really started trying to think with those patients that historically seem to be higher risk, morbidly obese, smokers, a lot of metaphyseal comminution where even if you thought you did your best, you left a little distraction instead of compression or aligning things. And any real situation for great instability, poor bone quality, or based on fracture pattern, you start to think, how do you enhance your techniques? Now, the danger always is with such metaphyseal comminuted fractures, you can make a construct that's too stiff, and then this can lead to other problems as well, including obviously non-union and catastrophic failure. And then finally, many of these patients that are elderly, osteoporotic, or they're periprosthetic distal femur fractures, these people need to be mobilized immediately because they can be subject to similar complications as hip fractures. So protracted time and non-weight bearing and limiting their activity can have really a catastrophic means on their systemic system. So with combining all of those different balls in the air, so to speak, we thought, how can we get these patients up? How can we get reliable fixation? And how can we make controlled instability? So you don't want to be overly stable. You don't want to be unstable. So you could call it controlled stability or controlled instability and dial it in to allow for immediate weight bearing in these groups. And also avoid the issues. Even if you went on to healing, sometimes you would fade into varus and you would have other mechanical complications. And so that really started the genesis of this. And then when thinking into this a little bit more, then you start thinking, well, the implants behaving separately versus together in the proximal and distal aspect, what are the benefits of that? And I think we all can come to a consensus that stacking your distal fragment with as much fixed angle fixation as possible is really going to help you with that stability of the distal fragment. And then the thing is about spreading out that stability or spreading out that rigidity in the proximal fragment. So this affords you the opportunity to stack the distal fragment even greater. And then further stacking the distal fragment greater, the concept of unitization, meaning linking the implants, also can be helpful. So with unitization, then it also comes one of twofold. If you get a single point of fixation through both implants, that could potentially be an axis of rotation in the flexion extension plane. So optimally, if you can get 2 points of fixation, that's also going to help you. So that takes care of our distal fragment. In terms of our proximal fragment, then the same concept of using flexible fixation closest to the area of the fracture site, the most distal part of the proximal fragment. So frequently a non-lock screw or unicortical lock screw can be used. And then you really want to spread out your screws, because remember, this is kind of adding a belt to suspenders to keep your pants up. So the whole point isn't to make it super rigid, but to make it enhance stability. And that's really the direction that we went in with that. And then you can afford yourself the opportunity, depending on the needs for the side plate. If you bring that side plate up proximally and get it near the vastus ridge, you could potentially shoot a couple of screws through there because many of these elderly patients, by definition, are fall risk. That's how they got that fracture. And you could prophylactically even put some screws through the plate to stabilize their proximal femur, femoral neck, femoral head, in case they are subject to another fall. So that's kind of how this rolled out. Initially, when presenting the concept at meetings and throughout, some real concerns were raised, and they were accurate concerns. And the main concern was what historically would say is confusing the bone, combining a plate technique with a nail technique. But in reality, we're going for secondary healing here. We're not really confusing the bone, and these implants are all tools for going for primary or secondary healing. And so really all we're doing is doing supplementary fixation. So that's kind of how the genesis of this started in concept and then translating to clinically. And then I think many of our colleagues are seeing the merits of this and really following similar techniques, throughout the country and even throughout the world. So I think this has been a benefit.
In your manuscript, you discuss primarily using this technique in osteoporotic patients. What are your current indications and have they evolved?
I think the indications clearly are for extreme comminution, especially in an osteoporotic patient. An osteoporotic patient doesn't necessarily mean elderly. It could also mean, somebody on chronic seizure meds, a chronic smoker, or, they could be 40 years old, young person, but they can still have these problems. They can have systemic conditions like lupus or rheumatoid, but these are all really higher risk situations. So that metadiaphyseal comminution in a high risk patient, especially if they're obese, and really allows you to mobilize them sooner and I think safer. those are the main ones. Rich, anything to add to that?
Yeah, I think age is not really a cutoff, just like you said. But if the medial aspect of the distal femur and that metaphysis, even in a young person, if that zone of injury is extremely comminuted, I mean, we often see that with motorcycles, pedestrian strokes, stuff like that. That'll be also be an indication for me to use the nail plate technique.
Have you seen any failures of the nail plate technique in your practice, or?
So we
no.
no, and I'm actually finishing up. I wanted to get to over 100. Now we have over 100 patients in a multi-center study, and our heal rate has been 98%, something like that. There's one delayed union in a repeat non-union case, but other than that, everyone's healed.
Can you speak a little bit about the post-operative protocol that you guys are currently employing for these nail plate combinations? Are they all range of motion is tolerated, weight bearing is tolerated?
Yeah, we didn't start that way because as with anything new you're experimenting with, you may be a little apprehensive. You may lean back on some old concepts when you only were using one thing or another as opposed to both. Over time, as we build confidence and sort of results, pretty much the whole point of doing this is to allow people to be weight bearing as tolerated and mobilize them early and get all those benefits systemically as well.
Have you seen sort of maybe an earlier healing rate with these, given the fact that they're weight bearing on them, or have you found that it's not changed? I know some of these distal femurs can take many, many months to heal, and some have even very late failures.
So the late failures, again, is one of the things that we've avoided. There's studies fluttering around 20% of failure, even with isolated distal femoral plating. So that, as we discussed, we haven't seen. And in terms of healing, the average time to unions we've been seeing is give or take around 4 months. And it's been very, very consistent. That is the one thing that I have noticed. This is anecdotal, and another good thing to look at is the consistency of defined union. And it almost is always between 3.5 and 4.5 months. Rich, have you seen the same?
Yeah, and something that's interesting that you notice after looking at these X-rays for a while is that before this, I feel like the posterior medial corner of the metaphysis is always kind of the last one to show some fluffiness, and with nail plate, what I've been noticing, especially on the lateral, is kind of more abundant callus that is posterior and then towards that metaphyseal combination. But it's something that we've been seeing consistently with the nail plates around that time.
Awesome. Well, thank you so much, guys.
Well, it's been a pleasure, and thank you for inviting us to share with your journal club.
Thanks for having us.
Thanks.